The one thing that may happen, the link may shut down and then I have to restart it. So don't be surprised if that's something that I have to we have to re-enter into the Zoom meeting. So just to prep you guys. All right, let me share screen. So a little review from last time. So let's see, how can I do this? Let's see. All right. So, we're going over brachial plexus again. So this is another section of that series. Just as a little quick review. All right. Someone can say it or text it into the box. What nerve did we talk about last week? You can type it. You can unmute yourself. And I have the chat box open. Come on, we're playing for points here. Come on, let me see something. Close, Brian. Good guess.
I forget the name, but was that the one where we were trying to touch, like by our scap, or by our?
That's the we can't touch nerves. That'd be bad if we touch nerves.
Yeah, but was it like the one that was near there, like in that cluster?
It's close. Brian, that's a very good guess. Denise, come on, throw me a nerve. Sherilyn, throw me a nerve. All right. I'll cut you guys some slack. It's all right. I know. I just, like I said, I posted the new YouTube video. So we talked about the dorsal scapular nerve. That is the nerve that we were talking about last week. And now, saying that, what muscles did we talk about last week? Or the other week? Traps? No. Close. It's near the traps. So we're talking about shoulder motion. All right, think of, I'm going to give you the hints. The posterior aspect. It's close. It's around the shoulder blade. So what muscles were we talking about around the shoulder blade? Eric, that's very close, but that's today's lecture. I like it. Okay, so we're talking about rhomboids major, rhomboids minor. And I believe it's pec minor. No, it's pec minor. Levator scapula. So those are the three muscles that we were talking about from the last lecture. I'll just pull it up real quick for you guys because that's something important that I want you to remember. So we were talking about rhomboids minor, rhomboids major, levator scapula. Oh, no, I was right. Pec minor. Oh, sorry. This is part of the brachial plexus. Sorry. This is not dorsal scapular. Pec minor is not dorsal scapular. I apologize. I knew that was right. But yeah, so levator scapula, rhomboids major, and rhomboids minor all are supplied by the dorsal scapular nerve. And let's pretty much go into it. Pretty much controlling the motion of the shoulder. We're talking about, just pop it up here. So rhomboids minor, we're stabilizing, retracting, elevating, and internal rotating the scapula. We're talking about rhomboids major, stabilizing, retraction, elevation, internal rotation of scapula. Beauty, again, like I said, rhomboids major, minor, they're going to have the same function. It is controlling that scapula when you're moving overhead motions. And levator scapula helps with downward rotation of the shoulder and let's see, elevates the scapula medially. So when they're talking about elevating the scapula medially, it's really like this manner. It's not like it's going this way per se. It does help bring the scapula upward and up and medial, as you can see, toward the spine in this direction. All right, so moving to the scapula, which is what I was leading to. So you have downward rotation and upward rotation. You have a anterior sling and posterior sling. What that essentially means is we refer to this as a tilt, the tilting of the scapula. Certain muscles engage the scapula to bring it backward, and then certain muscles bring it forward. External and internal rotation. So like I was saying, what the rhomboids does, and the rhomboids major, rhomboids minor. So we're doing internal rotation, external rotation. Now, an old little lecture is pretty much that mimics the glenohumeral joint for external and internal rotation, like the rotator cuff muscles. And then you have the elevation, depression, raising your shoulders up, pushing your shoulders down. And then that's going to help with, or that's the motions that we're looking for. And then retraction, protraction. I'm trying to see something. Myself. Nope. Let's see. Where's me? Okay, there we go. All right. So this is the brachial plexus. Just going through it again. You have your roots, trunks, divisions, and cords. As you can see here, I'm focused on the long thoracic nerve this evening, and it is supplied by C5, C6, C7, and a branch of C8. That is what the nerve pathway when it comes to this. And let's continue. Like I said, this is the nerve components. This is where it's positioned. Again, like I said, this app is great to have. 3D Essential Anatomy. I know someone said there's an updated version, which hopefully this might load, but while it's loading. So pretty much, again, you're going posterior, it's innervating this structural muscles, and the term's called deep. Whenever someone is referring to something deep versus superficial, it's deeper, so it's closer to the body. It's more, it's beneath. It's like lower in the ground type setting. So the muscular supply for the long thoracic nerve is the serratus anterior. Some people refer to it like the Superman muscle, a boxer's muscle. That's what we like to refer it to at times. And it is deep to your lat and your pec major. So this is a fairly deep muscle superficially. You can get to it palpation-wise. The function is we're looking at abduction of the scapula, upward rotation, which we talked about before, depressing the scapula, holds medial border of the scapula against the ribcage, and can, if the scapula is fixed, may act to elevate the thorax. This is important for spinal injury. I'm just going to talk about the shoulder first. So this muscle plays a very good, and it's a very large muscle. So this is the whole serratus anterior, very large muscle. It does a lot of control for your scapula. When this doesn't work, a lot of your overhead motions become deficient. We're talking about that depressing the scapula. So when you're doing that overhead motion, you are upwardly rotating, okay? And the serratus anterior is also depressing the scapula against the rib cage, and it is avoiding that medial aspect of medial elevation. Perfect. Okay, so when I type in, okay, so when we're talking about the shoulder blade, like I said, we're that medial control. The fibers that it's attached to do not allow it to we call it laterally rotate. So the scapula is not going to pull this way. It's going to maintain, it should maintain its position here. This is important, and I will further down the lecture, but this is what we're looking at here. All right, see its attachment to the ribs and the scapula medially. Remember, it's controlling that medial positioning and depression. That's how it's going to depress. When it engages, it's going to pull that scapula down as it is elevating up in overhead motion. So the reason why this is important for nerve injuries, so people with spinal cord injuries, they need every single possible muscle available when it comes to their condition. A lot of times they more or less, they're lucky if they have like a T4, T5, their respiratory pattern's pretty much intact. What they can do to compensate for breathing at times is because, as you can tell structurally, that it is attached to the rib cage. When you stabilize your shoulders to like a position and you breathe in or breathe out, you can almost engage your serratus to help you lift up and allow breathing to occur, to assist with breathing. So when you're in PT school, you'll talk about when you're at a certain level, what muscles do you have available, what muscles do you not have available. So this is why it's important to make sure that, especially in the neuro setting, you have available muscle structures. Now, I wasn't able to, I had a little trouble finding this, but this is from my OCS lectures before, but you have different fibers. You have your upper, middle, and lower fibers of your serratus anterior. They do accordingly those motions of whether it's a medial rotation, depression, upward rotation. So those certain fibers are associated with the regions. I apologize. I want to get that info to you. I just got to find it. So what does the serratus anterior help you with? Overhead motions, acceleration of throwing, swimming, doing a push-up, pushing open a swinging door. So this muscle is fairly important. You use this muscle more or less every day, especially if you're an athlete. Okay, so what is basically going to happen is I'm going to go through some videos that I was able to make, going through some of these exercises. So it's not your stereotypical, I'd say, like motions. So I'm just going to go through those. And I'm just going to talk. Let's see. Okay. All right. So we'll start with this one. All right. Oh, great. All right. Well, we'll see what happens. All right. So this is what we call D1 flexion. So as you can see, I'm just going to minimize this because I can't see anyone. Okay. So as I am going up, that upward motion and down. So this is what we call D1. So again, like I said, you're never gonna, you can isolate certain structures at certain times, but okay, all right. So right now I have 9 minutes. So about 9 minutes, things gonna cut out. So I'm gonna resend the link and we'll reopen it. Okay. So pretty much what happens is you're incorporating you're not just isolating serratus anterior, you're incorporating it into the motion, which is important because there's only so many muscles that we're going to engage with this motion. So you're getting your biceps, getting deltoid, you're getting a little bit of wrist, elbow. So you're going this way, so you're going up in that direction. So we're always going to diagonal motion. And again, if anyone has any questions on these exercises, feel free to let me know. Again, I'm going to post these on the Instagram, but you guys are getting a preview of them now. This is D2 extension. So this motion is going extension. So extension is always downward. So I'm starting up top and I'm going forward. It is similar to that baseball throw. The one thing that I'll say is like this should be angled a little bit higher. Research has said about 120 degrees. This is like 90. Listen, I'm only so tall and I don't have anything that high, but it's the importance is just that motion in general in that downward direction. So, downward motion. So you're getting a little bit of serratus with that as well. Let's see. Flexion. And the beauty is this. Listen, you get multiple. You're able to engage the serratus with these activities, as well as other muscles. So you're benefiting the patient, providing these exercises to them. I think this was, okay, this is D2. So in school, they kind of go through these directional patterns with you. There's a certain sequence to it. But D2 is this diagonal direction. I call it like the disco, D2 disco, if you want to help yourself remember it that way. So you're just pulling the band up and then bringing it back down. And again, you're also engaging your shoulder blade as well. You're doing a shoulder squeeze that I was doing. This is an oldie. Some people remember this one. So surprisingly, when I did my research on this, I said, 90-90, external rotation, beautiful exercise. You get in rotator cuff, and you actually engage a little bit of serratus anterior with this. So that's important because we're also getting the cuff in this motion. So that's the big deal. So this is one from one of the research articles I found. So I call it like a bear hug. So this is the front position. You're basically trying to give a hug to somebody, I guess, or I was trying to think of like trying to flex on someone, I don't know, in the gym. But as you can see, my shoulder blades are coming forward and retracting back. So I just want to side to you. Now the key is keeping those elbows straight because again, remember this is a punching motion, right? This is that punching motion. So that's what the serratus muscle is assisting with. You're doing that punching motion. Now I probably say my form isn't the greatest, but the goal is to avoid a little bit of that hiking of the shoulder. But again, the idea is you're getting that punching motion. Push up plus. Down, and then you can see that little bit right there. As I come up, I am trying to press my shoulder blades further away from each other, and that is what we call the push-up plus. And then I squeeze my shoulder blades back, and I go down. And I try to push up. Again, like I said, my forearms are right, but the goal is, now listen, this is sometimes tricky. I actually had a patient today. I had to try teaching him this. Couldn't do it. He was like, I can't keep my elbows straight and do this motion. I was like, okay, listen, we got to practice this. This isn't something that's easy. We got to get your serratus to fire better. So when you're at that top of that push-up, you want to, again, like I said, push further down, and you'll quote separate your shoulder blades a little bit more. But you're getting that, using that punching motion.
I got a question.
What's up?
So like a regular push-up, would that also activate that muscle?
Correct. You are correct. Yes. Regular push-ups do engage that. The progression in the article that I was reading, it did say doing the push-up is fine. The progression or / addition that you can do is doing the push-up plus.
Okay.
Now, position-wise, so this is something called a quadruped. This is when you're on your hands and knees. Okay, it's basically doing the same idea. You're squeezing and you're pushing your shoulder blades away. So for someone who can't do a push-up, bang, this is what they can do. They can get into this four-way position on hands and knees. You're squeezing and then pushing down. This isn't easy. This takes a lot of control because I'm trying to keep my elbows straight. Some people have that tendency to bend their elbows. Let's see. So this is a more stereotypical exercise you may see in the clinic. So this is just keeping the elbow straight and just monitoring and just trying to punch up that little extra toward the ceiling. Now the one thing that I had to actually look this one up, which is good because I consider it more of a chest motion, but actually just doing a press up like this engages the serratus as well. So you're getting a few things involved in here, obviously, but like I said, this activity engages the serratus as well. Going back to, so the one thing that they talk about is whenever you're doing research on exercises, you want to look at the EMG. That is referring to the muscular output for a certain exercise. Looking at some of these exercises, I highlighted a couple. Doing a push-up plus with the feet on the chair has been indicated to be a very high recruitment of serratus fibers, as well as glenohumeral internal and external rotation at 90 degrees of abduction. So you talk about being efficient, you give them the most relevant high EMG study exercise, you're doing a great job. You're getting them the most effective set of exercises that they can work on, or what you're targeting. Now listen, some people, they're not there yet. This is hard. Doing a push-up plus on a chair can be very hard for someone. I'm not saying do that the first day. I think you might like destroy their lives, but you know, that's okay if that's your if that's your intention. But listen, doing it on the wall, doing it on your knees, your feet, that's why it's a progression. You have to get them started somewhere. When you progress them from the wall to the knees, the feet, you know, you're putting them in a great direction. And that's telling them that means they're getting stronger. Doing some home exercise program as well. So let's see, dynamic hug. Again, like I said, this will be available to you guys. This is the directional concept of where to position yourself, shoulder positioning, your degrees of motion. And again, similar to the quote, like a hugging action for the dynamic hug. Oh, and there we go. All right, good stuff. Yeah, I knew that was going to happen. Hopefully everyone's going to re-sign into it. Perfect. Awesome, Denise. All right, 1, 2, 2 more. Awesome, Sherilyn. Yeah, we're just waiting for one more. Come on, Eric, you can do it. All right, cool. You made it. Fantastic. All right. Glad everyone's able to do that. I did not know if that was going to be a tough problem. All right. Okay. So these are some of the exercises that this group of individuals did that showed effective serratus anterior activation. So again, setting your patients up like this is you're benefiting
Anthony,
them.
can you share your screen again?
Oh, aha! That's totally relevant. Yes, I knew that. All right. All right. Sorry. So, just kind of circling back. These are the positions that you can use to set up the exercise. This group utilized the dynamic hug and serratus press as two effective ones as well, using bands. You can easily incorporate this with a cable column as well. So I was talking about injuries to the nerve. Check this out. I'm gonna try catching it a little bit here. This is someone who has a long thoracic nerve injury.
Hi, my name is Paul, and this is Louise. Louise comes to see us because she's been having some weakness in her left arm. She's 60 years old. It started about 6 months ago, where just had some progressive difficulty lifting the arm overhead. She's not having any pain associated with it, so that's been kind of difficult as far as the diagnosis part of this, but what I would show you today is that she has good rotator cuff integrity on the left side. But you can clearly see in a second why she has difficulty with her overhead activities. So the first thing I'm going to ask you to do, Louise, is lift your arms both straight up overhead as far as you can go. And you can see we have some instability right here. Now we're going to let you bring your arm down.
Now watch this part.
And then I'm going to have you hold right here and try to hold my arm up. Hold your arm up. There you go. Good. Now don't let me push your hand back. All right, now can you bring your arm behind your back?
Bang.
Okay, and you can see
Look
this.
At that is so bad.
Significant amount of scapular instability.
Her scapula literally pops out. So this is what we call like that lateral rotation. Her scapula is laterally rotating. There's no stability whatsoever. So that's why it's important for that serratus anterior, that medial control. That is medially controlling that motion. If there's none of that control, that's what you get.
Serratus anterior is not working at all and not holding her down. So basically her glenohumeral joint is not functioning in the right way. So we have to start wondering, did she develop a virus? She doesn't remember having sustained an injury to the shoulder. She has no obvious radiculopathy except for maybe a little bit of loss of reflex, C5, C6, C7, all three levels. But we're not having a lot of pain, and she says she can modify her lifestyle to deal with this loss of motion. She doesn't want to undergo a large surgery to help fix.
So, he's going to go into a little bit more detail about that, but yeah, that's what happens. And then I'll let you guys kind of look through this. So this is looking at your scapular alignment. The reason why, if you don't have that control of goes into several other muscles when it comes into scapular dyskinesia that we were talking about. So this is a nice little clip that you guys can watch on your own. So my clinical viewpoint is this. What exercises are the patients doing? Monitoring their position. One of the exercises that they were talking about is a lot of these over 120, over 90 degree range of motion for the shoulder. That proves that's fine, but you have the increased risk of impingement along the shoulder with that range. So you have to be mindful. What position is their shoulder in? Because you don't want to have them do an exercise where they keep getting like clamped in the AC joint, glenohumeral joint, or scapulothoracic joint. And a lot of these times you see it with these overhead repetitive motions. Are they doing too many sets? Are they doing too many reps? What are they really focusing on at the gym? And like I said, also, so these consistent overhead motions actually places a strain on the nerve itself. So that constant overhead motion, you're stretching that nerve. So these are articles you guys can access. It talked about, I think you should be able to have access to everyone. If not, I will personally send you it if you can't get access to it. But this is a nice little, these are my, my sources, and, like I said, the stuff that I use. So that is my little lecture on serratus anterior. I'm just going to pause it here just so I can, just give me a second here. Okay. I'm just going to test it out with this. So again, thank you everyone for hopping on. I just want to do a little housekeeping things. And then, like I said, I'll share this later if we need to. So what I am trying to create, I have decided to come up with subcommittees and groups for the program. Everyone more or less that's in the program has been that will be assigned a section, a group of people to work with, as well as myself, to collaborate, to work on outreach programs. Again, like I said, like, you're not doing it alone. I'm doing it with you. We're just having discussions because I want you guys to gain that experience when it comes to kind of learning, whether it's reaching out to a hospital, reaching out to an office, nursing home, hospital, working on like social media outreach, undergraduate, university outreach. So let me just share my screen here. All right, can you guys see my screen? Okay, fantastic. So, all right, so pretty much these aren't set in stone. And like I said, you can I kind of selected people right now. That doesn't mean you can't go from one group to another. I say I wouldn't do too much. And obviously if you want to join in, that's not an issue, but I'll manage that. So pretty much I have the clinical observation task force and virtual. So I have myself, Denise, and Brian. I added you that one. Again, I'll try to give like a little summary. Pretty much it's us trying to reach out to skilled nursing homes, hospitals, neuro clinics, pediatric clinics, just trying to acquire some type of individual, or whether it's myself at a certain time during the week, to give you guys a virtual session with each setting. I've been doing some research with the universities that I'll talk a little bit about next, but they don't mind virtual. Their virtual experience is valid now. So a lot of that is looking at certain settings. And some universities are still staying at a strong point of acute care or subacute care settings. So that's important to me because I need to get you guys experience, whether virtual or in person, through that. So that's one of the things that we're going to work on with this team here. Like I said, I'll reach out to each group individually to kind of give a little bit more detail and what I'll have you guys do. The next one, so our college cheat sheet. So I realized that there's obviously a lot more PT programs than I realized, which is great for everyone here. I will say that I'm gonna kind of cut it down because it gets a little too much of a headache at times. But pretty much I am encompassing everyone in the program. We are doing this, whether it's per state and things along those lines. Denise is very familiar with this. I believe Amanda, the other student I have. So pretty much, I'm going to show you guys a quick glance because we want to get you guys a nice cheat sheet when you're applying to schools, giving you a nice little rundown of what is required from the university. Now, again, these are what we're going to do is obviously this is the first year. This is very unique this year because it's COVID. So, like I said, I have the university here, the GPA requirements and GRE scores, number of students accepted, the tuition cost. Excuse me, the one thing that that will be added and what you guys will add is, this is important, the CAPD accreditation expiration. When you take your board exam, you need to be accredited. Your school has to be accredited by the time you take that exam. Do not risk it when you're applying knowing that your school is not accredited. There's been several instances where I've heard of different universities, they're a PT program, but they're not accredited. So people would go, and I don't know what the conversation was, but that's not good. You want to avoid those schools. And then obviously you want to talk to, like, for example, like Seton Hall University, theirs expires next year. So when you are applying to schools, you want to make sure you know when their expiration date is, their CAPD expiration, because listen, you'll be a first year, second year. Oh, 2022. What's going on? Where's the accreditation? Where's the update? So it's being on top of the university themselves just to say, hey, listen, just checking in, as you're applying, you'd be like, hey, what is your status of the CAPD accreditation? As we go more. Okay. So I have the clinical observation hours required from each university, the letters of recommendation, prerequisite courses. For those, again, transitioning from like a certain degree and wanting to pursue PT, this is especially important for you. And or pursuing PT in the undergraduate, getting your prerequisites done. So making sure that you have all these credits that line up. Let's see. Okay, so the other little tidbit, which is nice. Listen, college is expensive. So what I research is, can you take prerequisite classes at a community college? So I want to make sure that, you guys at least have that information available, because some universities are very stingy. They're like, no, like, oh, you have to take, I'm just saying Seton Hall, you have to take Seton Hall graded classes. All right, fair. And always be careful if you are transferring from another school to another. If you are taking prerequisite courses outside of university, when you take at a community college, you want to make sure that these line up. Make sure those like whatever schools that you apply to, you could almost double check. Say, hey, like, I'm taking classes at Essex County College. I'm taking biology with a lab. Is this okay? Do you guys accept this credit? And I'll be honest, you want to get that in writing. I don't care if they tell you a million times. You want that in writing, and or you find it somewhere. Because I've seen a handful of times where people get screwed because the university said, yeah, we take the credit. And then it's like, oh, they changed it. So that's something that I always like to make sure that you guys are aware of, because listen, if you can take some credits at a different university or at a community college and save some money, absolutely, I want you to do that. Just be aware that some colleges aren't like that, and they would like you to, quote, parallel the community level course and make sure that it is up to their level or standard. So that's just something that I always like to say, and especially like as you're going different, staying local or far for community classes. So pretty much the people in the program, this is what you're pretty much going to look like. We're going to go through different states. You'll be assigned a state, and pretty much the requirement is 2 universities per week to a maximum of 10. So I modified that, so we're only doing 10 universities. Again, you can always link stuff, but try to get as much detail that's not like over crazy. I'll show you the ones I did. So, and listen, I've emailed universities. I've emailed this university in particular, actually Clarkson University. So, listen, people, it might take them like a week or 2 to get back to you, especially nowadays with all the holidays coming around. So don't be frustrated. And then, listen, they have a bunch of courses here that, that are relevant to the curriculum. This is the first time I've heard a pre-PT program for Clarkson, so from a university, excuse me. But it's cool because it gives you prerequisite and relevant coursework. So these are little programs that, hey, like, I like to be in courses and relevant things. So it's not just being a bio major. It's all right, cool. I can apply to Clarkson and be like, all right, I can try to apply to this pre-PT program. Doesn't necessarily guarantee you a spot, but it puts you in a better situation. They look at that. All right, so let's see. So stop the share for right now. All right, let me see.